Yeah, so everybody, now we're going to switch gears a bit and have more of a conversation. Michael Mieri, the CEO and co-founder of Agmon Health, has joined us, and we're going to have a little bit of a two-way conversation here, right? So we're not just going to hear from Jeff, but we're going to hear from Michael, and we're going to have some back and forth conversation to about some broad topics here. So I thought we'd first talk a little bit about organizational buy-in as a broad topic. Obviously, adopting technology, is a challenge. It affects the whole organization, and different organizations make buying decisions in different ways. So I was wondering if you could talk, Jeff, a little bit about, Highlands as an early adopter. How does Highlands evaluate technology, and then dive a bit into, how'd you work with your APPs and your nurses, right, who might be impacted by new technology, right, to get their buy-in and get them involved in the assessment process.
Sure. Yeah, happy to talk about that. The first piece is going back to the notion of spending a lot of time and due diligence on selecting the right vendors. Getting into that process and knowing that you're working with somebody that has first and foremost the ability to develop quality tech, but also a willingness and understanding that they have to work side by side with the practice. Not go develop a tool and then come to the practice and say, hey, here's how you should change the way you do things so that you can use our tool. More along the line of let's come in and observe how Highlands is or how your practice is working. How can we build tools to help you along that journey, make you more efficient, but not completely turn your world upside down? That plays forward into the buy-in process significantly, especially when you're talking with the end users. Because if we can minimize the amount of new things that they're going to have to learn how to do, minimize the disruption to what they're doing already, or adding more minutia, more clicks. You know how docs love to count clicks. Well, nurses and advanced practitioners do too. That allows us to get better buy-in and understand that these people are coming into it knowing, okay, this is going to make me better. This is going to make me more efficient. So when we've done that piece of legwork in advance, and then we're showing them new tech and showing them exactly how it's going to layer into their workflow to free up time for them to take those mundane tasks off their plate. It your buy-in shoots up significantly. It's never going to be 100%. You're always going to have some who I like to call Eeyores out there, just they're constantly negative on something. Doesn't mean they don't come along for the ride, but there are always those people who are a challenge in an organization. But what I see is this approach takes that equation from what might be a 50-50 buy-in, not bought in, to more like an 80-20, 90-10 type of proposition, and that makes the whole process go easier.
And I think also from our perspective as a vendor, we really try to meet the users where they want us to be, meaning that if eventually the MAs do not want to switch to another platform where they currently use Encore EMR as an example, we can automate the process as much as possible so they get messages within Encore versus getting used to another dashboard, another platform. But to be honest, we also have heard from a couple of teams where they said, no, we actually prefer your dashboard because it's so much cleaner and we can see, what's coming next, what tasks are due, whether they've been completed or not before the next office visit. So we are very flexible and we try to customize the workflow based on, on the center's needs. And I think also from our perspective, as part of the decision-making process, other than looking at the user experience, we also try to look at the different modules that the center will be interested in down the line and what's the potential return on investment, and how can we together spend time to estimate that and actually track it over time and see the impact. So I think that, that's from our perspective, what we've seen that worked out well so far.
Yeah, I'm glad you brought up the ROI component, Michal, because that's kind of a hot button for a lot of people, right? A lot of healthcare providers now don't want to buy new technology unless there is a clear ROI. So Jeff, what was your perspective, the Highlands perspective on ROI? Just in general, assessing technologies as well as when you're involved in assessing Agmon.
Sure. What I'll say is that we've learned that assessing ROI with AI endeavors is a little bit different than what we're used to. I know most practices, if you're like me, I like to be able to build an ROI on things that I can really hold on to, I can really grab onto. And many times that comes in the form of, it's new revenue you're going to bill for, or it's a revenue share or something like that. What I see with AI, and it was definitely applicable with Agamon, is that the most clear ROI element off the bat is really going to be around reduction in staffing hours for many of these tasks at least. And what we've done with chart prep or I'm sorry, not chart prep, but the referral coordination off the bat very much is that it's making us more efficient and automating some of these manual tasks. The long-term or I should say, what many people see or envision as a short-term ROI proposition is that, well, you're going to be able to reduce staff. Our philosophy is a little different. We know we're going to be able to use less staff time, but we don't want to use AI as an exercise to go in with a sickle, so to speak, and just start cutting massive chunks of the company. That's not something it's not beneficial long term, because you have good people there that you can actually, as you're implementing these technologies, you can actually reassign and grow slower as an organization as far as your FTE count. Also, I mean, just the negative morale hit, around massive cuts. That's not something that we wanted to do either. In this case, though, we were able to realize a double whammy where we had the immediate, or I should say, the what will be a sustained long-term kind of through good attrition, a realization of less FTE hours. But in this case, where we actually have the imaging center, a good example, like I mentioned, of the CT that doesn't get followed up on, but the Agamon software is reminding that external provider, hey, you need to order a CT. Obviously, that translates to revenue for us, whether that's getting the revenue on time and faster when you should have, which is a good thing, or in many cases, maybe the provider just never followed up at all and never ordered it. That's just completely lost revenue. That's a little bit tougher to quantify when you're going through an ROI process, because you don't know exactly how many scans that's going to amount to, but you know it's there. You know that it's going to be a win. The question is how much. So when we looked at that, we know we're going to be able to reduce staff, but we know that there will be a benefit as far as the scan revenue. That was enough for us, in combination of looking at the quality of the work that they were doing, to know we should partner together and get something done.
Interesting. Michal, did you have anything you wanted to add or ask Jeff about that? Oh, you muted.
Sorry. I think from our perspective, we look at the different modules and try to measure as much as possible the return on investment in advance. So in the case of chart prep automation, as Jeff mentioned, we look at the time we save for FTEs, as well as the number of cases where we prevent last minute cancellations. We've been hearing over and over again from oncologists who mention how, a day before a visit, they have to cancel a patient appointment because the colonoscopy hasn't been done, the biopsy hasn't been done. And so, the time is obviously worth money, and also it's a very poor patient care to have to cancel at the last minute. And so we definitely prevent these cases as well by making sure that enough time prior to the visit, we notify the MA that everything is in place, or that there are some missing items. And you know what? A week before, you need to reschedule this patient, and not a day before, so that the MRI will be completed on time. So that's also something that we measure as part of the ROI, this type of impact. And I will just say that in terms of the imaging, this is something that we've been doing with also large health systems over time, and we usually take 1 year of data prior to kind of deploying our solution, and use this as a baseline. So we measure what's the adherence to follow-up prior to deploying Agamon, and we then can kind of, obviously it's a bit seasonal, but we can measure the difference between what happened prior to Agamon as well as after Agamon. So that's one way we measure. We also do it in real time, because we actually only communicate missed follow-ups. We don't communicate the ones that can be completed organically. So we have different ways of measuring that. And that has proven itself quite well so far.
Mhm. Now, there are a couple of interesting points there. One, and Jeff, I'd like you to comment on this, was like, do community oncology practices understand or have a sense of, how many missed follow-ups or what their leakage is, or like, the current state of your business, right? Is that kind of a black hole for most?
I mean, the easy answer is that it's going to vary from group to group, that's for sure. Um, a lot of that, right off the bat, access to quality data is going to vary mightily from group to group, because what you're alluding to is, knowing how many patients you lost outside of, what you could have brought into the practice. You kind of have to have good access to claims data to really be able to prove that, and know exactly where they've gone to. Now, there are several different organizations that you can partner with to be able to get access to that, but it's another cost. So it's one of those things you kind of have to pay to know if you really lost somebody or didn't lose somebody. Um, so I think that's in our case, we do have access to claims data where we can see exactly what is our leakage rate, and know in our area, which we're fortunate that we have a very strong presence in our area. But still, that doesn't mean that we have 100% catch inside of here. It's nice to be able to look at some of that data and know where they're going. And what you can do if you do have access to that is be able to then have a better feel of, well, by improving that care coordination and the relationship with the referring provider, how can I swing that a little bit? How can I make a 40% leakage into 35 into 31, and keep going down that line? But I'd say, yeah, having access to quality data is a variable and would be a key piece.
Mm. The other thing that Michal touched on was really the whole chart prep, visit prep conversation, right? Getting patients back so that doctors, fill all their slots, as it were. Why don't we just talk about that a little bit? Why don't we just start with the difference between, say, visit prep, chart prep, because, there's different terms that get thrown around a lot. Maybe you could share your perspective on those terms and, how you differentiate between them at Highlands. And then maybe we could spend a little bit of time talking about which ones take longer, and then the impact of, not just automating those processes, but eliminating, those physician gaps, those empty slots with the docs.
Yeah, the terminology is going to fluctuate from group to group, but essentially, the way I see it is, you've got your new patient coordination chart build out, as far as the going out and getting documents, a large number of documents that are outside the organization, and bringing those in. So you're building out the chart before they're ever even seeing a provider, before they're ever getting a lab. Due diligence, so that you're as built out as possible, so that you have diagnoses in place to be able to support the initial imaging and some treatment and things like that. That's piece number one. And then from there, it's your follow-up. It's your regular, what I would say, your we would call it just chart prep, or your daily visit prep, where it's happening the day before the patient's visit. Sometimes, and maybe there's some build up to it, but I know, in our team, at least, our physician teams are spending a lot of time the day before proofing and building that out, last couple hours of the day or so. That piece is nonstop every day. It's happening for every patient that's coming in. There's a lot of man hours that are spent on that piece. And going back to what I think the perfect applications of AI are, it's automating the repetitive formulaic type of tests that it's A plus B equals C every time. That's chart prep, whether it's for a new patient or for follow-up visits, is going to fit into that vein, as far as the pieces that you have to have into.
Yeah, maybe a follow-up on that, Jeff. So thanks for that. Maybe comment on it seems there's huge variability, not just from practice to practice, but from doctor to doctor, and how they prefer to practice, and how well they document or don't, and need help doing that. It seems AI can really kind of help to some degree normalize that, and hopefully kind of reduce maybe the docs that are the long pole in the tent, or the processes that are the long pole, and really have a lot of human intervention.
Sure. And yeah, that's perfect application for an AI agent. being able with initial algorithm programming to say these are the elements and this is the structure in which you want the data to be presented back to these physicians and these physician team members. That's great, but it's a learning agent. So as it goes through, it's going to be able to improve that efficiency, improve that accuracy, bring the right elements back to the right team members. I think it's a tremendous opportunity, especially like when we think too about staff retention, turnover. I don't know about the other people on this call, but it scares me the idea of turning over a physician nurse because I got to bring in somebody to learn that doc all over again. That is not a 2-week process. That can take as much as a year, sometimes even past that, to be able to learn all the idiosyncrasies and nuances of working with that physician. And if there's technology that can help with that, not replace it altogether, because the interpersonal dynamic is very, very key. But if it can help with that, to be able to continue to spoon up the right pieces of information to a physician, that's extremely valuable.
And what about
Yeah,
from
on
an,
that note, sorry.
go ahead.
I just to add on what Jeff just said, we spoke with a couple of surgeons who actually mentioned that their teams use a set of guidelines, and they have to train them every time when they bring new people on board, and and that doesn't make sense in this time and age. Especially, I'm sure that these guidelines get updated over time, and they need to change, and that also caused them a lot of issues when it comes to procedures, so very high value procedures that have to be canceled last minute because some of the tests haven't been done on time because they didn't follow the guidelines. So I agree, these are areas where AI can be deployed and save them time and help them. And I think we we haven't seen much resistance, at least to what we have been doing, because I think these are the parts that most people just hate to do. I think they prefer to spend time with patients rather than with these EMR notes and bureaucracy. So so far, at least from our perspective, we've seen some very positive feedback from the MA, APPs, and physicians.
Yeah, Jeff, I imagine your folks would be happy to spend more time with patients than on paperwork and chart prep.
Oh, absolutely. I think I mentioned before, they don't these certified personnel don't get out and get their licenses and go through all that training so that they can sit in front of a computer and do paperwork or electronic paperwork.
Right.
They do it because they love, the most part, they love working with patients. They want to give care. They want to be a part of that. Yeah, freeing up the logistical, administrative side of the job as much as possible just allows them to do more. And if back to the competitive piece, if our practice is doing that, but potential competitors around are not, that's a competitive advantage for us as far as the enjoyment of being at work, and getting satisfaction and engagement out of that employee.
Yeah. And another interesting thing that Michal mentioned was the standardization, standardized processes, standardized guidelines. I mean, one thing about technology is you can, program it, if you will. You can set it up according to guidelines, and then it just repeats itself, right? So you don't have to retrain software once it's originally set up, which I guess alleviates some of that training of employees, right? You've got some turnover, you've got people doing different things. Your technology can keep things adhering to these clinical guidelines over time. Does that make sense?
Absolutely. I think that's what McCall and I are both emphasizing right now. It's a good summary.
Let's talk about care coordination for a second here. Maybe just start off by how do you define it, Jeff? And how do you manage care coordination now at Highlands? And then, how do you foresee technology improving your efforts? And,
Sure.
where do you see, the biggest improvements coming from?
Yeah, care
as you
coordination
implement
is a very
technology?
broad term. There are a lot of things that you could put underneath it. The way I would choose to define it, I guess, in a quick, easily understandable way is really any point where you've got a warm handoff or you need to have a warm handoff from one service or aspect inside the practice to the next, to the next, to the next, to the next. Sometimes that handoff is to an external provider and then back into the organization. That care coordination component is making sure that that handoff is in fact made and is a warm handoff. That's something that is, you've got the wheels greased as much as possible, and so the patient journey, it feels seamless to them. You're limiting the amount of time that they are feeling like, you know, they're left not knowing what's next or not knowing when the next piece is scheduled. Having that as optimized as possible, it's going to lead to just ultimately better outcomes with the patient. But the patient experience is going to be significantly more well received if we have that consistently. If we're consistently demonstrating the capabilities of the practice at every step along the way, that we're navigating you through this care coordination journey. How AI can help with that is going back to some of the similar themes of removing with using easily predictable elements of the care journey and applying AI to those things so that you can again make them a formulaic process, and then bringing the time back to the clinician so that they can spend more time with the patient and bringing them through. All those elements add up to better care coordination.
Yeah, maybe just quickly, Jeff, so and how do you measure your success with respect to, I know you can't measure every handoff, every opportunity, but some of the key ones, how do you measure those?
Well, sure. I mean, in the past, it was a manual process. I should say somewhat manual. Some EMRs have some technology that help you to be able to cover some of because now you're back to closing the loop, and making sure that referral process was fulfilled. EMRs help with some of that, but not all the elements. There's still a lot of manual process that's there involved in that. AI absolutely plugs in very, very nicely into that. To be able to surface those key elements and keep things moving.
Great. Just to remind folks, we're going to just shift the conversation here a little bit to talking about IRA, revenue diversification, and some of the most favored nation stuff that Jeff mentioned earlier. While we're talking about that, please be sure to enter your questions into the Q&A window, because once we're done with this IRA conversation, we're going to take your questions, and then we should be in a position to wrap up. So, that said, Jeff, what sort of recommendations or advice do you have for other leaders who are looking to diversify the revenue and offset some of the, downward price pressures on drugs these days?
Sure. I mean, it's a simple equation at a high level discussion that you have a few options, right? It's either generate new revenue, reduce your expenses, or find ways through efficiency and optimization inside your practice to incrementally do one of those first two things, but it is slightly different because you're approaching it in a different way. Finding new revenue sources is not the easiest game, and it is completely variable depending on what state you're in. Going back to what I was saying about certificate of need, as it's not as easy as just saying, you know what, I'm going to throw in a PET scanner and generate new revenue. There can be variables that are outside of your control. As far as efficiency, that's absolutely something that everybody can do. We could all look more closely at our operations and see where can I be more efficient to be able to drive down this expense or be able to improve my throughput so I can bring in patients at a more productive cadence and generate more revenue that way. I think that what the IRA is showing, I do believe that practice preference, as far as the way we're treating patients, is going to play a big factor into how much the IRA impacts you. Good example, your shelf life, or I should say the ticking time bomb on a drug before it's eligible for the IRA is a 7-year shelf life past its original FDA approval date. If you're a practice that's heavily branded in your approach to treating practices, there are very few therapies that are going to fail that sniff test and still be the only brand option past year 7. You can call out one great example that would be to the contrary of that with something like Keytruda or Opdivo. But what you're already seeing is that you have alternatives with sub-Q and some other newer therapies that have come into the market that are alternatives. Still, IRA, your practice preferences are going to impact that, or are going to affect the impact of that piece. So that's directly going to influence how aggressively you need to be or not need to be on some of these things I'm talking about. My own perspective on it is that we all should be exploring every single additional revenue opportunity all the time. It shouldn't take the IRA for us to do this. And same thing for efficiency. But what we're seeing is that the IRA is a nice kick in the butt for some of us to get more motivated and start diving into these things and unpacking potential.
What about the considering addition of diagnostic imaging, as a revenue stream? Is
Yeah,
that?
then we're back to CON. That's
Yeah.
the first piece. If you are if you've obviously if you're in a state where that's allowed, that's one piece of it. Now, strategic relationships is another big part when you're talking about big money service lines, especially if you're in a competitive market. I know there are several scenarios across the country where maybe you're in a state where CON would allow you to do so, but maybe you are the only medical oncology provider and the hospital has all the pets, but doesn't have medical oncology. Well, you got to think through that really carefully because if you go put in a PET scanner, well, now you've ticked off the hospital. Maybe they answer that by bringing in medical oncology. So it's not just dollars and cents. It's not just state legalities. It's also strategy and thinking through that piece too.
Yeah, and I imagine some of this ties back to care coordination strategies.
Oh, sure. I mean, yeah, referral process is always going to matter in that. If you're not able to bring something in-house, well, then obviously the care coordination element with referring providers is going to be key to making sure you're having good communication, good flow of data back and forth, so you're getting those results back in the chart as soon as possible.
Let's see. What about Michal? Anything to add?
Yeah, so I don't have anything specific to add on this one, but I was interested to ask Jeff a bit about, using AI platforms and tools, and you talked a bit about how you identify the right partner for you, but what other capabilities do you see or AI companies that can help you offset staffing shortages in navigation, support roles, as well as kind of help you drive more revenue for the practice?
Are you meaning like what other types of tools that could drive practice or
Yeah,
drive
what other
that, or
types?
or like other elements of the relationship with the vendor?
Both.
Okay. Um, well, let me go with other tools. Getting back to what I was saying about how you have a clinical and an administrative and a financial, at least our philosophy, at least for looking at these tools. There are several different things that I know that you look at that are right on the doorstep of taking place. A good one is cancer registry, as an example. So again, back to what I said about the best eligible targets inside of a practice or something that's formulaic and repetitive. Most times, submitting data to a cancer registry is very much formulaic and repetitive. I think that that's something where there's a tremendous opportunity for AI partners to be able to come alongside practices because, again, it's something everybody does. Every one of our states, we have to submit that data. And maybe some practices may have the luxury of having an HL7 interface currently to push that data across. Many don't. Many are having to log into a web portal and hand key that stuff in. There's a great opportunity to be able to get that manual lift off of practices' plates and, again, automate it with artificial intelligence.
Great. Thank you.
Perfect.
Just a reminder, folks, please enter your questions into the Q&A panel. I think we're going to switch over to answering some of the questions that have come in. Jeff, someone was asking about the role of AI to retain and attract actually staff. Right? You talked a little bit about, technology can, scare people, but what are your thoughts on using technology to attract folks?
Sure. I think a lot of that, I can comment especially on our market where it's still a small town vibe, even though we're approaching 750,000 people or so in Northwest Arkansas. It's grown very quickly, so everybody still knows everybody. How that plays as far as attracting people is that if we're bringing a working environment to our staff that's assisted by technology but also we're checking the other boxes that we need to make sure that we're addressing around making sure that the environment is someplace where people love coming to work, making sure that they feel that they're valued and they have management that supports them and develops them and trusts them. If we're checking all those boxes as well, but also layering in technology that is making their job easier, that's allowing them to do the things they love doing more, a small town environment, that reputation is going to bleed out from our practice into other medical groups that are here in the area where there may be people that might want to come and join Highlands because it sounds like a great place to work. I think that is an element where it can aid in recruitment for sure, just that reputation, the reputational element.
Great, thank you. Someone was asking, does your clinical staff use tablets? You had mentioned tablets as part of, potentially part of chart prep or visit prep process. Do your APPs actually have tablets, or is it all paper?
The only utilization we have of tablets in the practice is through Ambient AI for dictation services. So having those inside for the physician teams that want to use it, which is probably a third of our physicians that are using that tech. That is running from a tablet or in some cases from a phone. Our approach with tech, though, we put actual slimline PCs into the exam rooms, and then have the same approach actually back in our physician bullpens, where our nurses, medical assistants, and advanced practitioners are working together side by side, not siloed off in offices. They're all kind of in one collaborative workspace. That somewhat eliminates the need for us to be utilizing tablets. Many practices will use tablets at check-in with patients as well. We do have some tablet utilization through that to kind of ease the check-in process. But for the most part, I'd say we're not a high utilizer of tablet technology.
I have actually one more question then that I'm interested to hear, and maybe the audience would be too. You talked at the beginning about how you select the right AI partner and the different operational, clinical, financial elements. But once you selected the partner, then what? How do you assess the impact that the partner has made on your practice? And maybe you have some good examples to share on how
Sure.
it evolved over time.
Well, usually the vendor that's coming to us is going to be bringing usually one solution, especially this early on in AI, where there hasn't been enough time for many vendors to develop a plethora, an app store, so to speak, of 15 different applications. Maybe they've got one or two or three. Usually the initial use case or the initial implementation that we have is going to be that core technology that we talked about. But in that interview process, for lack of a better word for it, we're already establishing what the roadmap is. And roadmap can be a four-letter word for some of us in oncology, because I think we've been burned too many times by working with some vendors in the past who have said, "Oh, don't worry, it's coming, don't worry." I think that's a key piece of working to see what is the core underlying technology that's going to be used in these tools. And if the roadmap is relying on tech that is the same core technology that you built the first one or two tools off of, well, that's a good predictor that the roadmap is actually going to become a road traveled and not just something that's always going to be in the future. That's a key piece for us. So before we're signing any agreement, for the most part, we're having a phase one of usually the core technology that we were first looking at. But then phase two is already being planned in that initial agreement of, after we do this, well, then we want to move on to this and this, and sometimes even a phase three. And the timelines and deliverables can be flexible to a point in those contracts, because it's a partnership. You're doing this together. You're building new technology together. So expecting a completely static, predictable journey is maybe a bit unrealistic. But that process, that way of thinking, usually, well, with good evidence to back it up in previous endeavors for us, has shown that we get where we want to go and build some pretty cool tech along the way.
That's great. Thank you. And there was just one final question that came up about lung cancer screening. You mentioned you've got a pretty significant program. People were asking about automation in lung cancer screening. The role of automation, the biggest swings in that space. Any, just thoughts to finish up the webinar?
Yeah, you're seeing some automation as far as I'd say well, in our practice, it's not just lung cancer screening. We have a full-blown multidisciplinary team that their work flows into multidisciplinary clinics where we're actually seeing we'll see a new patient, let's say, and we'll use lung cancer as the example, but we have, I think, 5 other multidisciplinary clinics as well. But that patient's going to come in not only see a medical oncologist, but we actually have other disciplines from the community. They're there on site. So they're seeing pulmonology. They're seeing there's a radiologist is there. There's CV, spiritual care, palliative care. I mean, it's 5, 6, 7 different physicians and teams that one patient can see in one day. You can imagine, though, there's a whole lot of coordination, a whole lot of document coordination, scheduling, those kinds of things to be able to orchestrate that and get it done just right. There's a tremendous opportunity for AI to be able to help with some of that as far as the prep piece, but also in the multidisciplinary tumor board that follows, because those people are all, after they see the patients, they're all getting in the same room in our practice for the last couple of hours of the day to talk through the care plan of that patient. The AI could do a great job of grabbing the relevant information as they're cycling from patient to patient to patient to be able to spoon that information up in a way that's easily accessible and ingestible by the participants. Let's see, there was another element along that lines that I'm forgetting. I had 2 ideas in my head, but I think the other one went away. Yeah, darn it. It was going to
No
be great.
problem. No, that was super. That's great. That's terrific. Thank you. And we're really at the top of the hour here. So I just want to thank you, Jeff, for your time, and thank everybody who's joined us today. If you have any follow-up questions, please just email us at mark@agamonhealth.com, and we can get those questions answered.